Okay, since
And here in the room, Nancy with CHIPRA.
John Martinez, Quality Improvement Coach with Envision, New Mexico.
And Kevin Worling, Systems Analyst, IT Support for Envision, New Mexico. And just entering the room.
Kane Sharf, Envision, New Mexico.
And presenting today we have
Paula Lesueur, Family Nurse Practitioner with Envision, and the CHIPRA project, or SHIP project. Okay, since we have a lot to cover, let's go ahead and get started. Of note, this is just for New Mexico, for anyone who presents a case for a Molina patient. Molina reimburses for the work to do case consultation with our webinars. And as Kevin said, we're going to be talking about the guidelines for medical coding and documentation for pediatric overweight, obesity, and sexually transmitted infections today. The objectives for this hour are to increase knowledge and understanding of medical procedural coding, the CPT codes, and the documentation that's required. To become more familiar with HEDIS measurements, the Healthcare Effectiveness Data Information Set, and to increase knowledge of pediatric overweight, obesity, and STI clinical standards of practice. So why is this important? First, to showcase that school-based health centers do provide quality clinical standards, and we are part of the larger healthcare delivery system in this country and elsewhere, and that all of the organizations that are listed here, the Institutes of Medicine, the Medical Professional Organization, the National Center for Quality Assurance, and the Centers for Medicare and Medicaid Services all subscribe to HEDIS. So it is become sort of the organization that consumers, health plans, medical practices all look to and are reviewed and evaluated using the HEDIS measurements. I'd like to, at this point, also alert you to the handout. Kevin, can you bring that up? And show me how. Okay, so this is a Word document that was a joint endeavor by Colorado and New Mexico. Specifically, Dr. Maureen Daly in Colorado and McCain Sharf and myself here at Envision. And what we did is separate out the quality standards for adolescent practice. And listed on the first page are the ones that we are looking at with the CHIPRA project, and the HEDIS is this. In the first two is the same for EPSDT and some of the other indicators. And we've listed the CPTs and if possible, the ICD-9s, and also Welligent, which is our database for school-based health centers here in New Mexico, but also for the work that we're all doing between Colorado and New Mexico with the CHIPRA grant. Of note, I'm not going to talk about the depression anxiety clinical standards today, but I want to alert you that Dr. Dan Rifkin, adolescent psychiatrist here at Envision, has presented numerous times on depression and anxiety and the use of standardized tools such as the Patient Health Questionnaire 9 or the and the SCARED, which is the screening for child anxiety-related disorders. And in New Mexico, and I think in Colorado, we have a CPT code that's been approved by both states now to track the use of these assessment tools, and it is a reimbursable code.
In Colorado, as far as I know and as I understand, it's just for the PHQ-9 that's been approved.
Okay. In New Mexico, it's for either anxiety or the depression tool. So just to go through here, here's all the information that we've put together for pediatric overweight and for STI screening and for immunizations. I was reminded yesterday at a MCO meeting that if you're seeing a student in your school-based health center and just giving immunizations, at least in this state, New Mexico, because we're a vaccine for children state, we only are reimbursed for the administration of each vaccine. But we learned from the health plans yesterday, we were reminded that if we don't include a diagnostic code, an ICD-9 code, the claim will be denied. So those of you in Colorado might check on that as well. Because school-based health centers not only need to document the great work that we're doing, but also get reimbursed for the work that we're doing. Let me go back to the PowerPoint here. And go from current slide is this one. Oops.
Pressure, Paula.
Okay. Let me try again. There we go. Okay. Sorry about that. So let's just get started with the HEDIS measure for weight category diagnosis and counseling. This is as you can see, this measure is to document the weight assessment and counseling for nutrition and physical activity. And in pediatric practice, we do that using the BMI percentile. Visit data is obtained and then calculated based on this definition. So as your counter, your visit data is transferred into a billing document, then that's the data set that is pulled up and sorted looking at the percentage of children ages 3 to 17 that had an outpatient visit with a PCP or an OBGYN and whose weight is classified based on BMI for age and gender. So it's so important that we not only chart the all of the work we do, but we also include that CPT code and the particular ICD-9 code as well. So for weight category diagnosis, this is what we need to use to document that work. There are 3 sets of HEDIS measures to document the weight category and the counseling. So in pediatric practice, every child has a BMI percentile. The underweight, the healthy weight, the overweight, and the obese. And so that should be charted. Even if you've seen the student for a rash and this is their first visit, along with vital signs, a BMI percentile should be calculated and entered into your assessment and into your billing sheet. That's how we keep track of these HEDIS measures. So if you don't document that, you know, this HEDIS measure is not going to represent your work and your practice. So I will get into the differences between when you use the 278s and when you use the V85s. So let's just move on. The next ICD-9s that you also have to use to document this HEDIS measure is the counseling for nutrition, which is V65.3, and the counseling for physical activity, V65.41. So what I'd like to do is just use some clinical cases to highlight how you would make sure that as I said, not only the quality of your work, but that it's getting, your charting is complete and the billing information is also included. So this is a 15-year-old female who has been seen in the school-based health center before, and where it was noted that her BMI percentile was above 85. And so she comes in for a follow-up visit, and the office visit is a 99213, which is an expanded problem-focused visit. And the way you would chart how the work that you did is that you would assign a weight category diagnosis 278.02. And the reason I chose that primary code as opposed to a V code is that the patient presented, the chief complaint or the chief reason that the patient was there was for the 85th percentile weight category diagnosis. So that's the primary reason for the visit. So that's why I selected the 278 code. Then you would also go ahead and spend time talking about healthy eating and providing some counseling about that, choosing healthier foods, non-processed foods instead of the fast food selections. And then you'd also spend time talking about physical activity, how to increase activity to become physically fit. So in this one encounter form, you have met the HEDIS measurements for weight category and counseling. One additional item to think of when you're documenting the visit is that if 50% of your visit was 50% or more of your visit was spent counseling and coordinating care, and you document that, you can what's called upcode. Because if you just code the 99213, that means that you probably, spent maybe 15 minutes, but because you had to go into more detail with this 15-year-old about nutrition counseling and physical activity counseling, and you chart that you did those other activities, that you provided key messaging, you talked about a treatment plan and changes in lifestyle, you charted a referral, you scheduled a follow-up, that really, based on time, becomes a 99214. And just for folks in New Mexico, I've included, when applicable, I've included the reimbursement rate because it is significant. You want to get paid for the quality of your work, but also for the time that it takes to provide that quality work. So there's, a difference of about $29 for this kind of visit when you establish that you've spent more time with the patient. Now, you have to make sure that your charting is complete, and what I recommend is if your EHR may already have this in your papers chart, you want to make sure that you actually write down the time that you walked in the room with the patient and the time that you left, and then state that over 50% of this visit was spent counseling regarding nutrition, a fitness, care plan, etc. Okay? So let's go into case number 2, where this is a 13-year-old Native American male. This is his first visit. He comes in for a well child check, or he's has Medicaid insurance, so it becomes an EPSDT. And he has significant findings. His family history, there's diabetes in his family history. Both grandparents have hypertension. His BMI percentile is over 95. He has acanthosis, nigricans. But his labs that you can do in your school-based health center that are CLIA-waived labs are normal. So you go ahead and do your EPSDT visit, the whole complete comprehensive evaluation and physical exam. And based on his age, the CPT is a 99384. Your ICD-9 is the V20.2. And his weight category, I'm using a V code now because it's a secondary diagnosis, but it definitely signifies that his BMI is above the 95 percentile. Now, this is another coding tool that we have, that this is a well child visit, but in the course of this visit, I've got another diagnosis here. So I can use a modifier 25 and chart another CPT code, which is a 99213-25. 25 is my modifier that I'm going to attach to my office visit code. My diagnosis for that part of the visit is a 701.2, acanthosis. I'm also going to chart for the fasting glucose that I did in the lab, because I'll get reimbursed for that, for this visit. And then I'm going to order further lab tests that are indicated for a patient with acanthosis and obesity. So the lipid profile, the AST, ALT, and the hemoglobin A1C. Also in this visit, I'm going to go over the counseling using principles of motivational interviewing regarding lifestyle changes, focusing on the nutrition, physical activity. So on this part of my note, I would also add the nutritional and physical activity V codes. So what's important in this is that you have one set of notes that relate to the EPSDT and another set of your notes regarding the 99213 with the 25 modifier. There shouldn't be any question from the billing department or through the health plans, but your documentation is what will, if there's a question or you do get audited, that's why I'm stressing that the documentation has to be complete for both of these visits. Yes, McCain.
I just have a quick question. So in both of these cases, the patient had an elevated BMI over the 85th percentile. What if their BMI was normal? What would you do then?
If it was normal, this next case might allude to that, but if it was normal, I would, maybe because of lack of time with that first patient and that patient needed to get back to class, I could bring them back, use a V code of normal weight, but also what was evident in my last visit with the first patient was that she really didn't understand about healthy nutrition. She was really not physically active at all. So I, as part of reviewing the student health questionnaire and finding out that she was sedentary, she was on the computer at least 2 hours or more a day, there were other areas that I wanted to follow up. So I would bring that student back. Thanks, McCain. So this sort of speaks to that, in working in a school setting and knowing that students are also required to be in class and they need to do homework and they might have an exam. Instead of doing everything during an EPSDT visit, the other choice is to reschedule the student to come back to follow up for these findings that you have. So again, that's a clinical judgment. So if this was a new patient, I could bring the patient back with the 99213, as I've just mentioned, and it could just be a 99213, and I get reimbursed $50.32 in New Mexico. Okay. Now, in New Mexico, the EPSDT for a new patient is $150. For an established patient, I think it's around $89. So Maureen, you'll have to let people know in Colorado or they hopefully already know what their reimbursement rates are. So before I move on to STI, are there any questions? I've thrown out this handout and gone through these 2 clinical cases quickly. So if there's any questions on pediatric weight category assessment or counseling for nutrition and physical activity. Okay, wait, Nancy has a question.
Sorry, just one question. Paul, I think one of the things we've heard from providers is that because they're trying to use motivational interviewing, if a student's elevated BMI comes to light because they're there for an EPSTAT and they didn't actually come into that problem, that providers feel stuck if they do the motivational interviewing and the student says, no, I don't want to work on that. If let's say they're in the obese category instead of the overweight category, what do you do as a provider to not just leave it at that so that you can get them in to do these other services? Do you try to get the clerk to follow up in a more lengthy time frame, or what? Or would you try to do everything in the one visit instead of scheduling a follow-up if you sensed that they weren't maybe ever going to come back?
Well, in the spirit of using MI, if I, as a provider, I use the ruler. I provide the information to all students, no matter what the BMI is. Because especially if I'm reviewing the student health questionnaire and I see that there's need for education or counseling and regarding physical activity or nutrition or just general health, I will talk about what is, I actually use our Envision clinical posters on having more energy. Are you feeling healthy? Are you having trouble sleeping, moving, concentrating? Can I talk about your general health? And sometimes I'll say, can I talk to you about your weight or about your physical activity? And I wait for them to say yes or no. And then I bring up, on a scale of 1 to 10 or 0 to 10, are you interested in learning more about your body or about changing some of your eating habits or your physical activity? And then work with them. What comes out is usually, they're drinking 6 sodas a day. They're not doing any physical activity. So just working with them to see what their interest is. Mm-hmm. And then it can be a very short, on a scale of 1 to 10, how interested are you in cutting down the number of sodas? Well, I'm a 5. Okay. What could you, based on you're sort of in between, whether you're really committed or interested in decreasing your soda intake, what about decreasing it by 1? In the next few days, could you drink 5 sodas a day? How on the scale of 1 to 10, how confident are you of doing that? And just work with them. If it's decrease by 1 in 2 weeks, fine. Then come back and let's talk about it again. Mm-hmm. You just have to start where they are, and if they're not at all interested, I just leave the door open. I've got my key messages out. I've talked about what, all the different risk factors on that SHQ that come out. I leave the door open and I say, thank you. I really appreciate you're willing to talk about this. My door's open. Love to see you again.
Great. That's helpful. Yeah.
I think all providers have different approaches. I think we just need to listen and be respectful. Okay, let's move on to sexually transmitted infections.
Oh, I'm sorry, it's Crystal Andiano. I just had a really, really quick question.
Yes.
On the primary and the secondary coding, the 278 and the V codes, could you use them both at the same time?
At the same
could
visit?
you use obesity? Right. Is there any reason why you couldn't just say the patient is obese and they're also over the 85th percentile in BMI? Because
okay, whether you use, I think let me try and be clear about this. If you look at the percentiles, so 85th to 95th percentile is 278.02. It's also V85.53. So you could use either one, but not both at the same visit.
And you would use the 278 if it were the primary thing that you were discussing and the reason that they were there, and you would use the V code if it was like part of an EPSTAT or another sort of visit. It was a secondary diagnosis. But either way, it's saying the same thing.
Right. Does that help?
right, okay.
Okay.
Yeah, it helps. But yeah, just saying the child is obese and saying that they're between 85 and 95th percentile means the same thing, but it's actually coded differently. So that's why I was just wondering.
Right. Well,
Okay.
Yeah.
Overweight and obese are two different ranges. Is that what you're asking, Crystal? That 85 to 95 is overweight and 95 and above is obese?
Right. So if they're 95 percentile and over, they would be considered obese. So on my record, if I was referring them to a specialist, they would want to know if the child's obese, so that would be the 278. And for my sake, for coding or for documentation, I would also put the Z85 over 95 percentile of weight.
You know, Crystal, I think it's the same, even though, maybe ECW says when you put in a code, it comes up as obese versus over 95th. But either way, it's the same thing. They both mean obese and over 95th percentile. You can use either code to say that.
Right, okay.
Okay.
Thank you.
You're welcome. And anyone from Colorado, any other questions about overweight, obesity, coding? Has anyone else joined?
Thanks.
Okay. Has anyone else joined us, Kevin?
I do believe we've
This is Mike. I just got on the phone. I've been sort of watching via video, but this phone.
Thanks, Mike. Okay. So the HEDIS measurement for STI, we have one, which is chlamydia screening. And it is the percentage of women ages 16 to 20 that were identified as sexually active and had at least one test for chlamydia during the measurement year. So that's pretty straightforward. In school-based health centers, based on the CDC recommendations, it gives us a little bit more guidance because we are working in school-based health centers with adolescents, both males and females. And so I think it behooves us in working in adolescent clinics that we look at both HEDIS and the CDC guidelines. And the CDC says that routine screening of all sexually active females under the age of 25. There is no lower age point. So the definition is if a female is sexually active, she should be screened for chlamydia. And it goes further. It's saying that screening sexually active young men is not generally feasible or cost effective, but in our adolescent clinics, they are recommending that we screen all sexually active young men as well. And then the CDC also goes on to say that Neisseria gonorrhea should also be screened for in all sexually active women. So with the CHIPRA project, we have adopted these two measurements, the HEDIS and the CDC recommendations, and that when students reveal or fill out the student health questionnaire saying that they're sexually active, then our recommendations, guidelines that we're following in our school-based health centers in New Mexico and in Colorado is that both GC, chlamydia, urine screens will be done on all sexually active students that are seen. You know, it's a urine test, it's covered by Medicaid, it's easy to collect and then send off to a commercial lab. I will just want to remind people, and particularly providers, clinicians, that the urine needs to be collected. It's more accurate if the patient has not urinated in the previous 2 hours. So you're not going to get a really quality specimen if they have just urinated within the hour of seeing you. It really could be a false negative. So that's one screening question that the medical assistants should be asking before they get the urine specimen. I know sometimes that's difficult because, again, this time commitment of trying to get kids seen and back to class, and then are we going to get them back again? I guess if I was faced with, oops, this student might not come back, I would get the urine collection. I'd rather have one done instead of done, although the quality is important too. So I think it's just important for the school-based health center clinical staff to be aware of that issue. So this is a 15-year-old female, comes to this school-based health center for the first time, and she comes in complaining of a dry cough, sneezing, and itchy eyes. And she fills out the student health questionnaire stating that she's sexually active and she's not using condoms. So this is a first visit to the school-based health center. You need to do a complete past family social history, the review of the student health questionnaire, perform the physical exam that is appropriate, that links to the chief complaint. And because she's sexually active and she didn't urinate in the past 2 hours, you go ahead and collect the urine. So there are two visits here, two clinical diagnoses here. So it's an expanded problem-focused visit. It's a 99202. New Mexico, that pays $62.74. So I would chart two ICD-9s, the 477.9 for allergic rhinitis, and the STI screening. I haven't given her a diagnosis of chlamydia or anything else. I've done the screening, which is a V74.5. Let me go back to this one. And I don't know if this happens in Colorado, but we have many of our school-based health centers are sponsored by federally qualified health centers, and they use eClinicalWorks for their EHR. And they have been telling us all year that when they are providing a confidential service, and they want to keep that confidential in their EHR and a confidential protected file of their EHR, they then cannot also chart at the same visit with the same patient on the same day the other diagnosis. So they're missing out on a billing opportunity because they cannot chart both a confidential and a non-confidential visit. I Have you experienced this issue in Colorado as well?
This is Maureen. Is Lisa still on the call? I don't.
I'm sorry. Could you? Yes, this is Lisa. Could you ask that question again, please?
In New Mexico, we've learned from our school-based health centers that are run by FQHCs that it's paramount, to chart confidential services in a protected provider file in their EHR. And then the billing is also protected, so that parents are not going to get a EOB showing that their minor child got confidential services. So we're all very concerned about that. So when in this case a student comes in, and we see this often, they come in with a headache, they come in with a cough, they come in with an upset stomach, but they also are really bringing another issue up that's confidential. So how do you protect the confidentiality and also get reimbursed for the medical visit? And what we've been told that our school-based health centers are doing is that they're taking care of the thing that's most urgent. They're either bringing the student back for the confidential service and protecting that and charting that in the confidential file and taking care of, let's say, the allergic rhinitis today and, giving them a prescription or whatever the complaint, the treatment is. But there's a worry that they won't come back for the STI screening. Because what happens is, in their system, they can't bill 2 different visits for one patient seen on one day. So
right.
Can't...
So just so you have an understanding, we are not involved with the FQHC, and we have just started our billing process in the past year, and we have had multiple issues with the confidentiality problems. We do mark confidential within our EMR system, which should flag the billing company to not send a bill. We cannot guarantee that that would happen. So what I have done in the past, we're still trying to figure out exactly the way of tricking the billing system into not sending a bill. We are not chasing after the dollar, which we need to do better. We need to create a better system so that we can go ahead and charge for what we need to charge. We don't have a great answer to your question, to be quite honest. I think it brings up the point of, the confidentiality issues and how much do you put in the chart. I tend to put as much as I can in the chart, and if it's that important, then we were told to have a paper chart on this child that we can scan in. I don't feel comfortable doing that. I think it legally needs to be in the chart. So it's tough. It's a very tough issue. We were told don't put an ICD-9 code, don't put a CPT code. Well, then you're missing data. So
right.
We don't have great solutions.
Okay.
I want to thank Lisa for sharing, because this is Maureen. I think in Colorado, lots of sites are struggling with this, and I think people are doing it different ways. So this is something for our to-do list to try to help figure out what might be the best mechanism. And it might not be the same for every site.
It is an issue. It's probably not just Colorado and New Mexico. It's probably nationwide, and introducing EHRs and patient portals, and it's really complicating how we document the work we're doing and have really good data, showing that we're meeting HEDIS criteria. our standards, it's really become an issue. And I think a lot of it's a judgment call. It's a clinical judgment call about what is most important for that student at the time. And it's tough when the student walks in and this is the first time you're seeing them. And it goes back to, as a clinician, of really connecting and establishing rapport, within 5 minutes. And it happens most of the time with most adolescents, but I always worry about the student that I'm really counting on coming back, and if they don't, then it means that one of us in the school-based health center is going to track this student down and make sure that they get come in for their follow-up appointment. Paper charts, it's easy. You can just have a section of the chart that's all confidential, and you'll never release that section of the chart. And in New Mexico, our Medicaid insured students, an EOB is never sent out on those visits. And generally, our students don't ever have a copay. So there's no way that, so long as our billing departments know that they don't bill a secondary insurance, like they don't bill Medicaid and Blue Cross Blue Shield. They know that, like what you were saying, Lisa, on the billing form, you check confidential, do not bill. That's been working for us pretty well in New Mexico. But we've hit this issue about how do you protect in an EHR system their confidential services and still maintain the quality of your documentation. So it's something we'll just continue to work on and help each other.
Oh, good.
Okay, here's another clinical case. This is a 16-year-old who comes in requesting a pregnancy test. So she's had unprotected intercourse in the last 36 hours, possible exposure to an STI. She did not, condom was not used. She missed 3 days of her oral contraceptives prior to the visit, and menses was 2 weeks ago. So she's at risk for STI and pregnancy. So in our school-based health centers, we would do a pregnancy test. We would assess sexual health. Again, the student health questionnaire is really helpful for that. And we provide education and counseling, use of condoms, assessing relationships with partner or partners, interest in wanting to become pregnant or waiting until after graduation to start a family, all those issues. We continue and talk about STI and contraception. And I always, at this point, let students know that we have expedited partner treatment here. I think you do in Colorado as well, that if she had a positive result, we could treat her partners. They either could come in or we could give her the medication to give to the partner. So in this case, and again, this is one clinician speaking, so I know providers vary in how they would manage these clinical cases, but I would go ahead and give her Plan B and birth control pills there right in the office. And I would code it as a 99213. I would code for the pregnancy test and then order the urine GC chlamydia to be sent out. And then my diagnosis code would be V74.5 for the STI screening and the V25.09 for the contraceptive management. And I would be sure to document that she had an appointment to return for follow-up and to get results. And at that point, if it was positive, then would definitely go ahead and see the partner or give her medication to give to the partner. and also reported to the public health department as a positive STI. Now, the other thing I would also do is schedule her to come back in 3 months, not to see if the medication worked. If she was positive and she was given azithromycin, you don't have to bring them back for test of cure. You have to bring them back in 3 months because the reinfection rate is so high, and you want to make sure that she didn't get reinfected in the 3 months. That, yes, I gave her medication for her current partner, but in 3 months, was there another sexual contact and she was reinfected? So that's, then, and another note, you can tell I'm, get a little OCD when I think about pregnancy prevention and making sure that none of our students are lost to follow-up or aren't getting services that they really are requiring or wanting. And I'm just taking this opportunity because we have our Colorado partners with us. Some of our school-based health centers here are really looking at long-acting, reversible contraceptive methods. Since in New Mexico, we're finding that our teen pregnancy rate is still #1 in the country, and obviously condoms and birth control pills and even Depo are not really being very effective. So practices are now looking at use of IUDs and Implanon or Nexplanon as long-acting reversible methods in the teenage population. And the providers that we've been consulting with are finding good results, good tolerance of these methods with young women. So I just wondered if you're seeing that in Colorado as well.
I'm getting off mute. Not all sites here in Colorado can distribute contraception, but there are some that are using some of the long-acting methods.
Okay, good. Good.
This is Lisa. So we're one of those that fly under the radar, and we do a lot of referrals. And with our girls that we refer to our agencies that I've worked in previously, the long-acting is great, absolutely, and I think more training needs to be there, but more advocacy for the ability to do contraception in the school-based health centers is really needed. So that's all.
Thank you, Lisa. So to get back to this clinical case, are there any questions or additions, comments? Liz, are you still with us here in New Mexico?
Oh, hello.
Hi.
I don't know how do you hear me?
Yes.
Yes.
Okay, hi, I'm still here.
Does this last clinical case about STI and contraception, do you have any other comments or additions that you want to make?
Well, that's the way we would handle it, too. I would like to get trained to put in IUDs. We are putting in Implanons. I'm working on that.
Okay, we'll make a note of that because we have one of the UNM gynecologists is starting to work with our UNM school-based health centers and is offering, she has a private practice, and she's also offering to come into our high school-based health centers to provide IUD services. So if it opens up, Liz, and we can sort of arrange for her to do some training we will definitely get the word out to you as well as the others.
Yeah, I'm not sure what I have to do exactly to get trained. I did put them in the old days, but, that was a long time ago.
Yeah, I think I'm in the same boat. I haven't inserted any of the newer IUDs, and I think it's just, the technical aspects of the insertion is just different with each IUD. So we'll keep you on our list. We'll let you know, and we'll get the word out.
Great. I think something might be happening July 24th with regard to training for that for us.
Oh, okay.
At El Centro?
Yes, there's a meeting of all the school-based El Centro clinics somewhere. And there was some kind of an email, and it wasn't really clear whether it was just some kind of a training or an actual training so that, we could then be allowed to insert IUDs.
Okay.
Keep us posted if you wouldn't mind.
Sure.
And then, Nancy, you had a question?
Yeah, I just wanted to get clarification about the established versus new CPT codes and what makes you choose 99202 one time and choose 99213 a different time. And that may be something all the providers on the phone understand, but I'm not as familiar with the, and this may be different for Colorado, but the New Mexico encounter form has 2 columns with the established codes, including one for the expanded problem-focused visit, and then a new code for that. Are people supposed to be transitioning over to the new codes, or can they use both, or how does that work?
These aren't new CPT codes. It's the new patient. So if a new patient into your practice has one set of codes, depending on the severity and complexity of the visit, established patients are ones that you've already seen.
I see. So your clinical case 1 was a new patient,
right.
So they get the 202, and then the other young woman is established, so she gets 213.
Right.
Gotcha.
Now,
Okay.
It's a little tricky because an established patient who hasn't been seen in over 3 years becomes a new patient when they come back. And that tells the provider a new patient is different. You have to do much more with the history and the physical assessment and past family history, personal history regarding medications, surgery, hospitalizations. It's a much longer evaluation.
Okay.
Yeah.
So is it paid differently?
Yes.
Uh-huh.
Yeah.
Okay.
Paula?
Yes.
This is Belen in Silver City. I was wondering if we could get that one sheet that you pulled up with all the codes. Can you email that to me?
Yes, and John, do you know how I can pull that up again?
Probably.
It's a Word document.
It's
Close
do I close this one?
We'll get out of it.
I don't know.
I want to say before you run out of time, and Paula, this was fantastic. This is Maureen. I wish we had a Paula and her expertise here in Colorado on our team. We don't have this coding expertise on our team, but I wanted to let the Colorado sites who are on this call know that we really are trying to look into what resources we do have available regarding coding to provide to our school-based health centers, and particularly around our quality indicators. And there are some nuances. So some of the things, Paula, you mentioned may be slightly different in Colorado, but just wanted to say that. But thanks. This was terrific.
Well, we wouldn't have this handout, this table, without you, Maureen. And it's been very helpful for our team as well to differentiate between, CHIPRA, what is HEDIS, what are the CPTs and ICD-9 codes, and particularly what's being collected by Welligent, so that their database reflects the work that is being done in school-based health centers. So
So can we just go back to Belin's question for a minute? So Belin, this is available on our Envision website. If you click on our calendar on today's webinar title, it'll come up, and on the left-hand side, you'll see the options. You'll see the PowerPoint handout, and then this handout is also included in that.
The other thing to know is if you guys have colleagues in your clinics that you feel like this information is useful to them, they can go to the main page in some days from now and click on the upper right-hand corner where it says play videos, and they can, you know, see the video of this webinar if you feel like that would be helpful to them.
Okay.
As well as the handout and the PowerPoint being available on the calendar.
And again, as I said in the beginning, you know, we have webinars recorded from Dr. Rifkin on depression and anxiety. I have another webinar that's been recorded on EPSDT. So scroll and through and look at anything. And if you have any problems, our last slide in the PowerPoint lists all the staff here at Envision, and Clancy Tarbox with her email and phone number is on that slide. And she is the go-to person that if, you know, this technology is too much, just call her and she'll send whatever you want, okay?
Maureen, just before, it sounds like you have to leave in a couple of minutes. We learned, Paula and I yesterday at our MCO, School-Based Health Center Advisory meeting, learned that the the MCOs are willing, some of the MCOs are willing to do some coding training regionally with school-based health centers. And they didn't say this, but I assume it's at least in part because they want to meet their HEDIS measures and feel like school-based health centers could help them do that. So, you know, I know it's a different landscape in Colorado, but maybe the health plans could be your partners in providing some of that training.
Thanks, Nancy. It's a little different. We still kind of are Medicaid fee-for-service with a few exceptions, but yeah, I think we can find the expertise. And if Lisa's still on, I think Lisa's the only. Are you the only one on from Colorado? I'll be interested to talk to you more about what kind of your needs would be for coding.
I think that the take-home message is to know that the only way that school-based health centers are going to be, they're already recognized, but to showcase the quality work, we really have to make sure that what we've learned with doing medical record reviews with school-based health centers is that they're doing good work, but it's not documented, it's not coded. So it's not, those HEDIS measures aren't going to look very good. And so knowing, best practices is one thing, documenting it and coding it is so important. And in New Mexico, a number of school-based health centers cannot survive on the funding from the state. They have to be paid, they have to be reimbursed for their work. And I think a lot of us are losing that opportunity. We're not using the 25 modifier. We're not getting paid for the time that we're spending with complex situations. Many adolescents have more than one diagnosis. They should all have their weight category diagnosis. I know I've said that 3 times, but they have multiple diagnoses, and it's a complex issue. And providers should be recognized for that and be paid for that work. So I think that's the bottom line. And I, again, thank you, Maureen, for your help with this presentation, and McCain, and for all the comments that everyone made. And please check our webinar schedule routinely. We'll make sure that you're on our mailing list, because we have lots of different webinars. And I think we'll close for now. Thank you.
Kevin, do you need to take roll again for CMEs?
I got everybody.
Great.
Okay. All right.
Thank
Bye,
you,
everyone.
Thanks,
Thank you.
Paula.
Thank you.
Bye-bye.
Where are we doing? we have all hands.
Evaluation and management.
Evaluation and management.
Yeah, I know what you mean.
I figured that was something else. So I didn't want to put on my copy.
Yeah, there you go. I gotta go eat.
Somebody printed one of these, as did I, and they were there, so I figured maybe it was yours.
Well, I don't know who it was. I didn't have it. Do you want me to make a copy?
Welcome to CenturyLink Conferencing. Please enter your passcode followed by the... Please hold while I confirm your passcode. Thank you. Your passcode is confirmed. When you hear the tone, you will be the 10th person to join the meeting.
Oh, here's more.
Hi, this is McCain, Nancy, and Paula.
Hello.
Hello.
Okay, now I have 12 names. Should we go ahead and get started? It's still only about half the team, but it's four after. What do you all want to do?
And Sarah, Leslie, and Maureen were on a webinar that Paula was just teaching, so if they're not already on, it might be just one more second.
They're here.
Okay.
We beat you.
So we have both the implementation teams. We have one person from Academy Health. We have Rachel, Shannon from Apex. We've got Joe here from CDPHE, and myself. Christy's here from New Mexico Medicaid. I guess what we don't have is, let's see, to sort of cover all bases, we don't have Jody with us yet. But maybe we could go ahead and start talking about the minutes from the Albuquerque meeting. If you're looking at